So we'll move on now to biopsy conference. So I'll turn things over to Dr. Akilesh and Najafian. Go ahead, guys.
Okay. Hi, Matt. Hi, everybody. Good morning. Thank you very much. Unfortunately, I connected a little bit late to the prior presentation, but even that later part was very interesting. Thank you very much. So today we are going to present two very interesting cases. As always, I bet you're not surprised. For you guys. So the first one I will present, and the second one will be presented by Ram. So let me start with sharing my screen. All right. Is everybody seeing my screen well?
Yes.
All right. So let me see if the, okay, yeah, the presenting mode also works fine. So let's start. So before starting, I'm going to let me see how I can do that, because I would like to actually also check the chat box while, all right, to keep it open here. So please feel free. There are some questions about like differential diagnosis, what you think about this, and feel free to communicate through the chat box, as well as whenever there are questions about the case, and at the end for the discussion, just to unmute yourself and participate in the discussions. So let's start. Okay, so actually, Dr. Jefferson actually was intending to be here and present the clinical part, but unfortunately, he was not able to attend. So I'm going to present the clinical part as well, which adds to limitation, and probably you have to do more guessing, because I bet he knows more than I do about the clinical history of this patient. So the patient is a 64-year-old man who's presenting with elevated serum creatinine, has been hypertensive for 20 years, has a history of Graves' disease for a long time, has been treated, now is hypothyroid, has a history of kidney stones, 2 to 3 over the years. Creatinine was 1.5 milligram per deciliter about 5 years ago, and has had slow climbing, and currently it's in the range of 2 milligram per deciliter. And the patient has been under care by PCP. Symptomatically, the patient is well and with minimal ankle swelling. He denies systemic symptoms, dry eyes, rashes, joint pains, mouth ulcers, denies all of those. Physical exam was well, blood pressure controlled on ACE inhibitors. The patient has 1+ edema, ankle edema. Otherwise, everything is within the normal range. So labs, urinalysis shows 2+ blood and 2+ protein, 1 gram per gram proteinuria. Serum albumin is 4.3, no dysmorphic red blood cells, and some granular cast. Hematocrit 40%, platelet count 266K, serologies, ANA remotely positive, double-strand DNA borderline, repeat was negative, anti-beta-2-glycoprotein 1 positive, other antiphospholipid antibodies negative, ANCA negative, anti-PLA2R negative, serology is negative for hepatitis B, C, and HIV, complements within the normal range, and studies for paraprotein were all negative. So a diagnostic procedure was performed, and that's just the sentence that when Ashley includes that means the biopsy was performed, obviously. So the first question, do you do a biopsy for a patient like this with this history? And the second question is that, okay, what is your differential diagnosis? Okay, so secondary FSGS, IgA nephropathy. I have to say that IgA nephropathy was indeed on top of the differential. Was the only differential that, I mean, the biopsy was virtually performed to, as I was told by the clinician outside, to confirm that the patient has IgA, has been treated with that assumption for some time. APS nephropathy, okay, antiphospholipid syndrome, yes, okay. All right, anything else? Lupus nephritis, yeah, ANA was remotely positive, anti-dsDNA was kind of like borderline. All right, IgG4 related disease. Okay, very nice. We're getting fancier in our differentials. Okay. If you don't have any questions, let's move on to the biopsy and see what we saw. Okay, so the biopsy was good size, I have to say. As you can see, we have one core here, which is predominantly cortex, and the other core here, which is composed of cortex and medulla, up to 19 glomeruli per level section. 2 to 3 of them were globally sclerosed. And as I'm looking at this low magnification, I can see that maybe, yeah, there is some kind of like diffuse increase in the gray material in the interstitium. So let's get closer and see what we have. This is one of the glomeruli, and the great majority of glomeruli looked like this. So if you ask me whether this looks normal or not, I would say that it looks pretty normal, maybe just a little bit on the ischemic side, but otherwise the glomerular capillaries are patent. You can see red blood cells very nicely. Mesangial areas are not expanded. Does not particularly look like IgA nephropathy or any active glomerulonephritis to me. I'm looking at the surrounding periglomerular interstitium. That looks somewhat expanded to me. This glomerulus looks more ischemic with some corrugation of the glomerular basement membranes. I'm looking at the Bowman's capsule basement membrane. That is also corrugated. It's undergoing duplication or multiplication as well. The glomerulotubular junction looks like it's being pinched off. So now, okay, glomeruli did not particularly look exciting. Now I'm looking at the tubular interstitium. Let's see what we have. So these are the tubules that you can recognize. I mean, we have proximal tubules, we have distal tubules here. And some of these tubules, they have lymphocyte. There's inside the epithelium. I mean, there is some tubulitis, and it was interesting. I mean, grabbing my attention, actually, I mean, at some levels, I was asking how much of this could be artifact or not. But, you know, some of these tubules, it looked like they have a break in the tubular basement membrane. And as I said, I mean, I was questioning myself, how much of this could be artifact? How much of this could be real? But on some instances, this was present. Now, what about the interstitium? So the tubules, we are used to see them back to back in the normal condition, and these are definitely not back to back. Indeed, there is increase in gray material, which means that there is interstitial fibrosis, there is increased collagen deposition, and we have scattered lymphocytes. So indeed, there is interstitial inflammation. So there is some tubulitis going on. We have some regenerative changes in the tubules, and there is scattered inflammatory influx in the interstitium. Okay. Another view from the tubules and interstitium, again, some interstitial inflammation. It's not very intense, but it's present, definitely present. In some of the tubules, it looks like, I mean, maybe some duplication of the tubular basement membrane, some eosinophilic material, but most of them, I have to say that maybe like focal atrophy or just tubular basement membranes as usual or injured like the one that I showed to you. Now, this is PAS, periodic acid shift. And everybody can appreciate that these tubules are not back-to-back. There is quite significant expansion in the interstitium. But also, interestingly, in the normal histology, we used to see that this interstitial space in fact, has a lot of peritubular capillaries. It looks like when I'm trying to find peritubular capillaries, there's a rarefaction of peritubular capillaries together with the interstitial fibrosis. The vessels looked okay. These are interlobular arteries. And as you can see, they look fine. They do not have thrombotic microangiopathy. We were thinking of antiphospholipid antibody syndrome. Okay, so now with this, what is your differential diagnosis? Okay, I can read from the chat box your prior thoughts. IgA nephropathy, secondary FSGS, antiphospholipid, lupus nephritis, IgG4 related disease. Favoring any of those? Adding some more?
Was the patient still on propyl thiouracil or was discontinued?
I do not exactly know to give you the answer, but the patient was, as I said, was hypothyroid when presenting. TINU, okay. I was not given any history of uveitis particularly, but TINU chronic. Yes, okay. All right. With a smile, chronic T-cell mediated rejection. So may I convert it to chronic tubular interstitial nephritis, maybe? Ischemic nephropathy, but there were some ischemic fissures and there was some inflammation. Dense disease. Okay. All right. Okay, so let's move on. So of course, I mean, that was the light microscopy, but as you know, we also do immunofluorescence. So let's see what did we see by immunofluorescence microscopy. So you can appreciate that there are two glomeruli here. In the glomeruli, there is Bowman's capsule staining. So we have granular Bowman's capsule staining in the glomerular tuft, maybe a little bit in this one, nothing in the other one. Outside of the glomeruli, as you know, we move outside, we see that a little bit of arterial wall granular staining, but the real thing is happening in the tubular basement membranes. So we have granular tubular basement membrane staining, as you can see. Although even in this picture, when I'm looking, I see that some of the tubules, they show very intense staining, and it looks like some of them, they do not show much. But it's not only tubular basement membranes that are staining, there is something else that is staining as well within the tubular basement membrane. And what is that? So let's take a closer look. So we see granular, we can appreciate that this is granular, although, I mean, it's intense. Staining of the tubular basement membranes, and I have to say that these are with IgG, as you can see. And as I mentioned, we have some tubular profiles that they look smaller, and they do not show this intense staining that we have in the other tubules. What's different? The difference is that these tubules are bigger, as well as they show staining of brush borders. So these are indeed proximal tubules. Okay. So you can, if you want to add to the differential, please keep giving those to me. So this is another picture, again, with the IgG. And as you can see, Bowman's capsule basement membrane staining, tubular basement membrane staining, and brush border staining, clear brush border staining. And some of the tubules, they do not show staining at all. So I can see that Yoshio wrote anti-megalin. So do other people agree with Yoshio? So this is another picture from IgG. It was peculiar and very interesting to me because some of these tubules that appear to be proximal tubules because they show very nice brush border staining also show these dense and intensely staining large granular cytoplasmic basically stains. That's kind of similar, reminiscent of the tubular resorption droplets, but just more pronounced. And some of them were, within the cytoplasm in the middle, some of them were lined up by the tubular basement membrane. In the glomeruli, we had segmental, granular, peripheral capillary wall staining, as well as Bowman's capsule staining, as I mentioned. And that was almost throughout this biopsy. You can see the very nice granular peripheral capillary wall staining that if it was, uniformly present everywhere, I would have called it membrane nephropathy, right? With C3, kind of similar pattern of staining, Bowman's capsule as well as tubular basement membrane staining for C3. I did not see much C3 within the glomeruli. And of course, whenever we see TBM deposits, there are some conditions that come into mind that are associated with monoclonal gammopathies. So we pay attention to kappa and lambda, and virtually no difference between kappa and lambda staining, and they both mirrored what we saw by IgG. Okay, so would you like to add anything to differential, to what Yoshio suggested? Do you agree, disagree? Okay, so let's move on also to electron microscopy. So far, anybody has any questions? Okay, I see a ball, anti-LRP2 nephropathy. Very nice. Which is basically, the same as anti-megalin. Okay, so by Bilal also mentions heavy chain deposition disease. So the staining for IgG definitely also could raise that suspicion, although usually we don't see brush border staining. And kappa and lambda were both positive and mirroring the IgG. So electron microscopy, by electron microscopy, this is the LOMAG. You can see the capillary loops, glomerular basement membranes. Podocytes show some food process effacement, but it's not that extensive, maybe correlating with the subnephrotic proteinuria. But the glomerular basement, look at them. They're kind of irregular. Some areas they have this punch-out, moth-eaten appearance. Looking closer at them, we have these electron lucencies throughout the glomerular basement membrane with some invaginations of the podocytes going in. And in some areas, we had these ill-defined electron densities in the glomerular basement membrane. So in these moth-eaten appearance is reminiscent of like resorption droplets. Resorption of immune type deposits in the glomerular basement membranes. That's something we can see. And this was present in multiple capillaries. But not much obvious immune type deposits is also correlating with the immunofluorescent studies. Okay, so this is a picture that shows Bowman's capsule in the periphery of the glomerular tuft. And we have immune type deposits in the Bowman's capsule correlating with the immunofluorescence studies marked by the yellow arrow. And interestingly, in a portion of the Bowman's capsule also, we had an appearance of, you see like this dense line that is kind of similar to what we see in association with MIDDs. Okay, by immunofluorescence, we saw staining in the tubular basal membranes, and now by electron microscopy, we can identify that this is a proximal tubule because the brush borders are very nice, although the basolateral enfoldings maybe are a little bit simplified. And so this is tubular basal membrane, and we were seeing immune type deposits in the tubular basal membranes. Again, this is another proximal tubule, a little bit of basolateral enfoldings can be seen in a lot of mitochondria and small but frequent immune type deposits. And outside of it, we have increased collagen fibrils. In the vessel walls, no discrete deposits, but kind of peculiar. So if I want to walk you through, this is the lumen of a small interlobular artery, I would say. This is the endothelial cell. This dark line is lamina elastica, and this is the media in the outside. So mixed kind of, in some areas, it appeared to be mixed with elastin fibrils, with collagen fibrils. We had these, vague electron densities. Okay. So I see now in the list anti-megalin, anti-LRP2 antibody, which is the same, HCDD, and semaphorin 2B membranous nephropathy. This, as I showed you, I mean, the subepithelial deposits were segmental and very, very limited, although if it was more widespread, I would have included that as membranous nephropathy as well. So question, now, what would you like to do next? What's your next step with your differentials? Mass spec, okay. Well, yeah, we perform mass specs for multiple conditions, but for these things that you have listed, do we get for semaphorin 2B? Yeah, but we didn't have that much deposits in the glomeruli, unless we think that it's a primarily tubular basal membrane deposition condition, and we want to send the specimen to do mass spec on TBMs primarily. Well, I was thinking of something else, and I was thinking that maybe there is an antibody against the components of that are in the kidney that we were seeing the brush border staining for. And therefore, what we performed is indirect immunofluorescence microscopy. So basically, I'm showing you what we do. We get the normal kidney. We add patient's serum that we anticipate that there is an antibody against the component in the kidney. And then we add anti-immunoglobulin antibody, commonly IgG, depending on which immunoglobulin we're looking for, generally IgG, which is tagged with fluorophores. So if patient serum contains the antibody, it will go and connect to whatever it's against, and then we can actually do immunofluorescence. And in this patient, as you can see, there is nice staining of thick brush borders. This is a normal kidney. This is not the patient's biopsy. So thick brush borders are staining with patient serum as well as ANA. So you remember that the patient had also low level of positive ANA. So we see both in the, in reaction of the patient's serum with a normal human kidney. And then when we titrate, we can do that in levels and see that, what's the level of that antibody. So there is antibody against the brush border of proximal tubules. So this was the initial, actually, I mean, this is the initial diagnosis before we did the electron microscopy, and then we moved to other tests. So basically anti-brush border antibody disease or anti-LRP2, as it was also mentioned. In order to confirm that it is for sure anti-LRP2, I mean, that's basically the only recognized condition that we know with these features, but we have to test for presence of anti-LRP2. I don't have a good antibody and we don't have a validated test for that to confirm that basically we have anti-megalin or anti-LRP2. Further workup in this patient, IgG4 levels, IgG4 disease you also mentioned in your differential was normal. Indirect immunofluorescence assay that we did confirm the presence of that, and this also serum was sent to Arcana. They did the same thing that we did and confirmed that as well. Clinical course, the patient has been on rituximab 1 gram times 2. Creatinine remained stable, proteinuria reduced, repeat circulating ABB titer pending. So very quickly going in the differential diagnosis for the TBM deposits, look, if it's linear, granular. For linear, there are some conditions, it's polytypic anti-tubular basement membrane, or if limited to distal tubes, anti-GBM, linear accentuation, so modest linear staining can be seen in diabetes, of course, drug-induced, and non-primary amyloidosis. If it's monotypic, it's more in the line of light chain deposition. This is heavy chain deposition. This is a primary amyloidosis. Granular, if it's polytypic, the most common condition, of course, lupus. And this patient had a background of autoimmune condition as well. IgG4 related disease, other autoimmune conditions, drug-induced, BK. We had a case like this last week, right? And idiopathic hypocomplexemic tubular nephritis or monoclonal protein depositions as well. Usually not very extensive though. So yeah, megalin, which the name comes from its very large size, 517 kilodalton multi-ligand binding receptor that plays a crucial role in basically reabsorption of many proteins. It is on the apical side of primarily proximal tubules in the kidney, but also in some other cell types. It's quite concentrated in the clathrin-coated pits at the base of the brush borders and plays an important role in the endocytosis. It's, as you can see here, it's the from Human Protein Atlas that it's very much expressed in the proximal tubules, but to lower extent, it is also expressed in other cell types, including smooth muscle cells, as you saw, in other organs as well. In the heart, you have some expression. In the brain, we have some expression. In testicles and in some other organs as well. In general, these are older patients presenting with acute kidney injury and subnephrotic proteinuria. Majority of patients, the course is progressive, leads to end-stage kidney disease, transplantation, and it recurs in the transplant, although, I mean, has been not widely reported. It's rare. It's been associated with lupus, sarcoidosis, lymphoma. As you can see, majority of these patients are old, the ones that were reported in the series by Chris Larson and group. So, questions, follow-up, questions and comments. Please unmute yourself.
So Behzad, great case. I was just struck also by the staining pattern and the distribution of the LRP2 also in Bowman's capsule, or at least maybe the parietal epithelial cells.
Yes, exactly.
So it's interesting. We were just we're playing around with RNA-ish and fish in the lab, but we actually tried LRP2. It labels the parietal epithelial cells very nicely, in addition to the proximal tubules.
Yeah.
So it's probably, that's a specific probably stain for the antibody recognizing the antigen in that location.
Yes, yeah, thank you. Yes, it's in the expression in the podocytes is way lower, but in the parietal epithelial cells, exactly as you mentioned, it is expressed, and to lower extent in smooth muscle cells as well as in the distal tubules, very low, but we don't see staining in the distal tubules. Yeah, thank you. Very good point. Any other question? Yes.
For the electron microscopy with the immune deposits that had a moth-eaten appearance, if it were membranous nephropathy, would you call it stage 4 membranous nephropathy?
Yes.
Classification?
Yeah, but I mean, in this case, even that moth-eaten appearance was limited to some of the capillaries. But yes, if we have that quite widespread involving the great majority of the capillary loops, that would be consistent with a stage 4 in primary membranous usually. Other questions? Okay, I know that Ram wants to start. He has a very interesting case as well.
Great, thank you, Behzad.
Sure, go ahead.
Okay, let me share my screen here. All right, is everyone able to see that? All right, sounds good. All right, so this is, again, a very interesting case that Dr. Carrie Payne and Dr. Hawkins and I struggled to work through. It's still an ongoing case as well. And so we thought we would share with you today. So just again, as a, let me just get my laser pointer going here. So again, just as a reminder, if you're familiar with this patient, please just be mindful not to disclose any PHI, since we are recording and distributing these recordings online. So let's begin the case. So I'll, Alex, do you want to take it away?
Absolutely, and thanks for the invitation to discuss the case. It is a good one. So clinical history, it is a 53-year-old with really no past medical history to speak of. He, in late 2019, he started noticing worsening fatigue was really the first sign, and then kind of developed leg swelling and abdominal fullness. And on initial evaluation, he was found to have portal hypertension. He had multiple hospitalizations throughout 2020, volume related, just required paracentesis at times, or at times was just floridly volume overloaded. Eventually, things kind of stabilized for him in late 2020, where he was just kind of on a diuretic regimen and watching his diet very closely, and he was quite stable overall, although the fatigue was still an ongoing issue. So going into further workup, the initial referral, everything up to this point was at outside hospitals, so we have some of the records from all of this, but he established with hepatology here, and they did an extensive evaluation into what was causing there to be this portal hypertension, which included a liver biopsy. It was fairly non-specific on the report for the liver biopsy. They did not see signs of cirrhosis. They didn't see any really fibrosis in the liver. They just saw some minimal portal inflammation, some rare inflammatory foci, but yeah, non-specific. So their ultimate diagnosis, they did other, they worked him up for autoimmune diseases, viral diseases, kind of an extensive workup, and ultimately came to the conclusion that this was an idiopathic non-cirrhotic portal hypertension. So as part of their workup, they also did a 24-hour urine collection, which showed 5 grams of proteinuria, which led to him seeing us in nephrology clinic. At that point, serum creatinine was 1.1. Looking back for the past year or so, or since he had been having these issues, creatinine was pretty stable throughout that time period. Albumin was low at 2.6. Urinalysis showed some WBCs and RBCs. We did a specific glomerulonephritis workup that showed positive ANA, positive SSB, and then in terms of complements, his C4 was undetectable, normal C3, and we did, so all of his viral serologies were negative. The SPEP and UPEP showed an IgG kappa monoclonal protein, too small to quantify, and the free light chains did not show. It was a normal quantity and ratio, which, taking all that workup together, yes, we went on to send him for a kidney biopsy.
All right. So any thoughts at this point? I don't have the view into the chat box, so if someone could help assist me with that, that would be great. Thoughts in terms of this presentation and ideas for what might be driving this heavy proteinuria, hypoalbuminemia in this patient with low C4 but normal C3 and some monoclonal proteins at a very, very low level. And some evidence for an active sediment as well with RBCs and some white blood cells as well. Any thoughts?
Christine asks about cryoglobulins.
Cryoglobulins?
Yes, we did not have that on his initial, I mean, his hepatitis C was negative. We don't have the cryoglobulins from that initial assessment.
Okay. Let's see, I was able to pull, okay, cryoglobulins. Other thoughts?
Thrombotic workup?
Alex, was there
Thrombotic
any?
microangiopathy workup?
Oh, his CBC was normal, and he didn't have a, yeah, I didn't include it there, but yeah, his platelet count was normal.
His platelets were a little low because of his cirrhosis.
Oh, that's okay.
Or because of his portal hypertension, I should say, not non-cirrhotic portal hypertension.
Mm-hmm. And then Dr. Hazley suggests PLA2R, maybe for like thinking of a membranous nephropathy.
That was tested, but negative.
Any other thoughts for like perhaps a more inflammatory or a kind of a glomerulonephritis type? Okay, C4 glomerulonephropathy. Okay, Dr. Hall says C4 glomerulonephritis. Okay. The Paris suggests sarcoidosis. Okay, so that's another interesting idea.
There were no signs of it because he had pulmonary imaging, but no, I guess no evidence of that, and clinical evidence as well. Okay.
So we kind of jumped straight into the obscure entities. So what about just old-fashioned IgA nephropathy? Is that a possibility? Or some kind of IgA-related disease, given that the patient has some liver dysfunction as well? Any votes for that? Okay, so let's continue since we have a lot of interesting findings in the biopsy. So let's go to that. So we got a great core of kidney cortex, and we can see that there are several glomeruli that even at this power look abnormal, and we'll get to them in a little higher power as well. There is some inflammation or inflammatory cells, which at first glance looked interesting, and we'll get to that as well. And of course, the background in the parenchyma looks fairly well preserved. Most of the tubules are back to back. There's not a lot of chronic injury. Well, so if we look a little higher power, we can see again that the glomeruli are atypical. They look a little perhaps thickened and a little fuzzier as well. You know, and Alex also just wants to add in terms of the clinical history that there were no other signs or stigmata of lupus erythematosus, and all the other antibodies related to lupus were negative. So we just have the isolated low C4 in this patient. So, but returning to the biopsy here again, we can again see the glomeruli. We're not seeing a big time crescent or necrosis. The tubules are all back to back. A couple of these show a little bit of maybe acute injury changes. There's a little bit of cytoplasmic vascularization. Here we have a small interlobular sized artery, which looks pretty unremarkable. There's some chronic injury, perhaps a sclerotic glomerulus over here as well. And again, we have these infiltrates of lymphocytes over here. Looking again at the high power, the same glomerulus, again, you can see these cytoplasmic vascularization, some acute injury to the tubules, very minor and focal in this biopsy overall. Most of the tubules looked unremarkable. When we start looking at these glomeruli, we can start seeing that there are some very subtle abnormalities. So there's a little bit of thickening of some of these mesangial regions over here. These capillary loops look a little bit stiffly patent, and some of them look like they may have extra material or fuzziness associated with them as well, okay? So slight subtle changes in some glomeruli. However, other glomeruli had much more prominent changes. And so this, you can again see the mesangial expansion and hypercellularity. You can see a thickening of the capillary loops. This almost looks like a wire loop-like lesion that we would see in lupus, We have accumulation of this pink eosinophilic material, which is very suspicious for an immune deposit. Could also be the beginning of segmental scarring. However, when we look at other regions of the same glomerulus like this is more of a typical appearance for an immune deposit-like appearance that we could see with lupus. We also see some influx of inflammatory cells and occlusion of the capillary loop, so almost like endocapillary hypercellularity here as well. We also see duplication and thickening of the basement membrane contours as well over here. So we've really got changes that are both involving the mesangium and the capillary walls with influx of inflammatory cells in a minority of the glomeruli. And so it's kind of a mix of mesangial proliferative and endocapillary proliferative, or even in some cases, membranoproliferative type of changes as well. So I gave you the preview that, maybe this patient has liver disease, has got some signs of active glomerulonephritis. Could this be an IgA MPGN, which we've discussed previously in this conference? So let's go to the immunofluorescence and see what that showed. So first of all, there was no IgA deposits. However, there were immune complexes, and these immune complexes contained IgG, C3, and only kappa light chains, but not lambda light chains. So they're showing monoclonal restriction. And if you recall, the SPEP-UPEP demonstrated an IgG kappa monoclonal component in the patient's serum and urine. Now, the distribution of these deposits are both mesangial and in the capillary walls. So this mimics the changes that we were seeing by light microscopy. So all those the eosinophilic material that was accumulating in the capillary walls and in the mesangium of the glomeruli probably correspond to these immune deposits. This is associated with deposition of C3, but interestingly not C1q. So even though that C4 was low, we're not seeing evidence of activation of the classical pathway of complement on top of these immune complexes. So given the fact that we were seeing this very strong monotypic type of staining of IgG kappa, we decided to do a further characterization of the heavy chain isotypes to see whether it was IgG 1, 2, 3, or 4. And so that's shown over here. And so each of these, even though these look blank, there is a glomerulus in the center. I believe it's the same glomerulus that I tried to image. But really, the immune deposits within the glomeruli only stained for IgG1. So taken together with the previous study, we're looking at an IgG1 kappa monoclonal immune complex mediated glomerulonephritis. Okay. So we then proceeded to electron microscopy. And so here's one of the images. We're looking at the mesangial region over here. You can see that the podocytes on top here show extensive effacement of their foot processes, perhaps even some microvillus transformation, these little processes over here. And occasionally we'll see some electron dense material over here. And so let's look at it at a little higher power in this region. And here we can see an immune deposit, which actually has a vaguely microtubular substructure. So kind of like a little tube of penne, if you will. There were other regions that we saw, other deposits, which did not have any kind of substructure. Now, this made us think a little bit of immunotactoid glomerulopathy, but these are it was just too diffuse and inconsistent of a substructure pattern that we were seeing in these deposits. And so we didn't go all the way to thinking about immunotactoid. However, as we started looking around, we saw additional abnormalities in the basement membranes. Again, we can see potential immune deposits in the capillary walls. But many of these basement membranes looked markedly atypical. Okay, so there was a lot of splitting, some extralucency, irregular thickening. Again, you can see the foot processes overlying the basement membranes are extensively effaced. Here again, we can see the splitting and abnormal lamination of the basement membranes. And in some regions, it was actually very thin. Now, when we think about this in the context of immune complexes, as well as we can see maybe some other additional deposits, one consideration is that maybe this represents remodeling and reabsorption of the immune deposits, similar to what Behzad showed in his case just before. But given that there's actually some areas of the base membrane that are thin, we also considered the possibility of a disorder of base membrane synthesis, collagen 4, or an Alport-like spectrum as well. So the initial diagnosis that we had was that we have kind of a proliferative glomerulonephritis. It's associated with monoclonal IgG1 kappa immune deposits, both in the mesangial regions and in the capillary walls. And there was also this ultrastructural finding of abnormal thinning and splitting and lamination of the glomerular basement membranes. So do we just have a PGNMID? This is what this would be called over here, though this is typically seen with IgG3 kappa. IgG1 kappa is also commonly seen in that entity as well. So should we just stop here? What about all these other lymphocytes over here? They seem kind of unusual to us because there's not a lot of chronic injury. And we have a decent amount of these inflammatory infiltrates that are just sitting there in the parenchyma, very well circumscribed, sharply demarcated from the adjacent parenchyma. And very interestingly, they seem to be hugging the glomeruli that were affected by this proliferative glomerulonephritis. So we took a closer look at these lymphocytes. So they're very well circumscribed. And when you look at them at a higher power, they looked kind of monotonous. So when we think about chronic inflammation related to chronic injury in the kidney, we usually see what's called a pleomorphic cell population. So it's a mixture of lymphocytes, monocytes, macrophages, and other inflammatory cells as well, plasma cells. It shouldn't look homogeneous. But to my eye, these infiltrates look fairly homogeneous. They looked like they were mature lymphocytes, but they had some atypical features. And this is seen a little bit higher power in the electron microscopy. They had a condensed chromatin pattern that you see typically with mature lymphocytes, but their nuclear contours were irregular. Rather than being fairly nice and round, you can see that there are notches and divots in the nuclear contours, and that's unusual. So this made me think of a possible malignant process or a hematolymphoid malignancy here. And so we sent this over to our HemePath colleagues to evaluate further. So they did several stains to characterize these infiltrates. So here again, brown is showing a positive signal. Here you can see it's counterstained with the light blue to show where the nuclei are. Here is an aggregate of those lymphocytes. CD3 is labeling T cells, so you can see that they're not really composed of T cells, but they're really composed of B cells labeled by CD20. And these aggregates were also co-labeling strongly with CD5 and CD23. And taken together with other panels of stains that HemePath did, this is very characteristic of a chronic lymphocytic leukemia or small lymphocytic lymphoma, which is a malignant disorder of mature B cells. As you can see, they have a nice, strong immunoprofile with a positivity for CD5 and CD23. So again, this is a further characterization. They also showed that their Ki67, which is a mitotic proliferative index, was fairly low, around 10% of the cells for labeling. There's also this more recent marker, which I had to look up, called LEF1, which is a fairly sensitive and specific marker for CLL, SLL. So they call this a low-grade B-cell lymphoma, which was directly involving the kidney parenchyma and was also then producing this monoclonal IgG1 kappa protein as well, which we were seeing in the glomeruli. So this kind of triggered a further hematologic evaluation, and peripheral blood flow cytometry was done to see if there was actually lymphocytosis with these atypical cells. And sure enough, there was an abnormal mature B cell population that was identified. It comprised about almost 42% of the leukocytes, had the same immunoprofile, and had kappa light chain restriction as well, as we were seeing. So at this point, what we have is we have two things going on, which are really parts of the same process. We have a malignant B-cell neoplasm of mature lymphocytes. Typically, these CLL, SLLs do not produce IgG monoclonal proteins, but clearly this cell was producing that. And interestingly enough, we were seeing a direct consequence of kidney injury with this proliferative glomerulonephritis with IgG kappa. So I thought that I would do a review of the literature to see really how has this been seen before and what is the context that we've seen this in. So I pulled out this old study from our group here with Dr. Alpers, Nicosia, and Smith, to think about, what are the patterns of glomerular injury that we see when hematolymphoid neoplasms directly involve the kidney. So this is not a very common occurrence, but what are the patterns of injury that we see? So the most common pattern of injury that is seen is kind of an MPGN type pattern, which is what we were seeing in this case. And the most common type of malignancy that directly involves the kidney is again CLL, SLL, which is the case for our patient as well. So let's now consider the entity that we diagnosed, which was proliferative glomerulonephritis with monoclonal IgG deposits. So this, many people in the audience are familiar with this study as well, which looked at this, described this entity. Now, while IgG3 kappa was the most common combination of a monoclonal protein seen in this patient cohort, over half the patients, the second most common actually was IgG1 kappa, about 22%, which is what we saw in this patient. Now, they saw that the presence of this and even a monoclonal protein does not mean that these patients are going to develop myeloma. They also saw CLL and SLL in association with this entity. And they also said that you shouldn't see deposit substructure, though if you dig deeper into this paper, some of their cases did show deposit substructure. And they stated that type 1 cryoglobulins should be carefully excluded. So Alex, I don't know if the cryoglobulin studies are back yet for the patient or not. Do you have that information?
I don't think he's actually, they're ordered. I don't know that he's gone into the lab and gotten it done yet.
Okay, yes.
Yeah,
So that was another, yeah, thank you. So that was another entity that we invoked in our comment for this patient, since we were seeing this vaguely microtubular substructure, to rule out that there aren't cryoglobulins. And the reason for that is because cryoglobulins, of course, can have organized deposits such as this. And they can be seen in the context of chronic lymphocytic leukemia, CLL, such as this study has shown. And interestingly, just like we were seeing, some of our deposits were more amorphous, and others showed this vaguely organized substructure. And this is another reason that in the context of the patient's CLL, it would be good to rule out that this is not due to a cryoglobulin-like injury process in the glomeruli. We also, I mentioned when we were looking at the EM that this microtubular structure made us think about immunotactoid, though the structure was not consistent and uniform and as exaggerated as we see in this entity. And so, but it's important to realize that immunotactoid can also be seen with CLL, in addition to other types of B-cell malignancies and plasma cell neoplasms. In fact, of all the hematologic malignancies, CLL seems to be the most common association with immunotactoid glomerulopathy, which itself is a very, very rare diagnosis. And lastly, we have also found that there are cases of proliferative glomerulonephritis with monoclonal IgG deposits, which are also associated with CLL, SLL. And so again, these are really rare cases. You can see that there are just 2 cases. This is from our colleagues just up the road in Vancouver. And they also showed patients who had CLL who developed an endocapillary proliferative glomerulonephritis with monoclonal IgG1 again. They had 2 patients. One had kappa light chain restriction, the other lambda light chain restriction. But in this set of 2 patients, the patients had pre-existing CLL outside the kidney. It did not directly involve the kidney. But they did note that when they treated them with rituximab, in addition to other chemotherapeutic agents, this significantly improved the kidney function in parallel with control of the underlying CLL. So we have kind of an unusual combination of direct involvement of the kidney with this monoclonal proliferative glomerulonephritis with IgG1 kappa for this particular patient. So kind of the take-home points in the last couple of minutes here is that CLL, SLL is kind of the most common hematologic malignancy that can be encountered directly involving the kidney tissue on biopsy. Again, this is not common overall, but when we see that CLL, SLL is the most common malignancy, MPGN is the most common pattern of injury. Now, when we think about microtubular organized deposits, we can think about a variety of entities, and there are others that are not even listed here, such as lupus, for example. But PGN-MID, cryo, immunotactoid, all 3 of these can have organized deposits. All 3 of them can also be associated with CLL. And the bottom line here for this patient is that treatment of the malignant clone is really the primary directive for therapy, because that should be expected to improve the kidney symptoms as well. So I'll turn it back to Alex here for the final words.
Yeah, don't have too much follow-up. It's still fairly early in the course of his treatment. He was just referred to hematology. Saw them just over a week ago. So, and this is their ultimate impression, is that same thing that Ram just mentioned, is that it's the CLL SLL that's driving this. And he is scheduled for a bone marrow biopsy next week. Just to give you some initial insight into their thoughts for treatment, it's going to depend on it will depend on the bone marrow biopsy how extensive the involvement is, but it would either be rituximab or a more specific CLL regimen with ibrutinib.
All right. So we're right at the hour, but if there are any burning last-minute questions or comments, we'll be happy to take them.
There's a great case.
Did you guys go back and look at the liver at all to see if
Yeah.
it has the cells?
We haven't yet. We can pull that up and see if that was actually involvement again. That's a good point.
Yeah, I mean, low-grade lymphoma is notoriously hard to diagnose in a liver biopsy, so I would definitely go back and look at that.
Sounds good. We'll do that.
How often do you see like CD20 positive cell infiltration, but the IF is negative for IgM? Seems the patient's IF was negative for IgM.
Yeah, that's a good point. That's a good point. Yeah, so these lymphocytes. So that's why a good point about CLL SLL is generally they're mature lymphocytes, but usually have not class switched to an IgG isotype. So in this case, it was unusual because this patient had an IgG1 kappa, but interestingly, in these mature lymphocytes, they have very low levels of surface expression. So which may not be detectable necessarily by immunofluorescence. I went back and looked at the immunofluorescence and did not see any staining of these lymphocytes, which were present on that specimen as well, for immunoglobulins or kappa or lambda light chains. If you remember by flow cytometry, the kappa light chains on the surface were very low as well, and that's typical for a CLL SLL. All right. Well, thank you very much, and thanks for the comments. We'll take a look at the liver biopsy as well. And happy Friday to everybody.